So welcome to your first cross-sectional lecture. We will be covering a lot of information over the next few months. It's going to be really important to keep a close eye on that course calendar to ensure that you meet all of the deadlines. Not all of your assignments and exams are going to be due Sunday at midnight, so very important that you monitor the D2L announcements and your course calendar. These are the objectives for this lecture. To better prepare for each weekly quiz, it's going to be really important to review these objectives again after the lecture. Make sure you can answer all of them. If you're having difficulties understanding one of these objectives, make sure to review that area of the chapter or lecture again. If you have any questions, don't hesitate to email me or call me. So before we're able to recognize and locate anatomy in cross-sectional images, we need to review some of our anatomic positioning terms. Hopefully some of these are review from either an anatomy class you've had in the past, either in high school or college. But anatomic position, when we're looking at anatomic structures, it's important to remember this specific position of the body. So anatomic position refers to the body looking straight forward, their arms are down to their side, palms are up facing out, and toes are forward. True anatomic position actually kind of points those toes down. So palms up, toes pointed down, looking straight forward. This is anatomic position. Again, hopefully these are familiar terms already. If not, take a little bit of time to review the pictures in your book and in this lecture, because this is very critical for understanding cross-sectional anatomy. So when we're talking about these directional terms, remember we're thinking anatomic position. So we see the first figure here, the girl is in anatomic position. So we have anterior. Anterior is going to, of course, mean the front portion or towards the front. And then posterior is going to be the back part of the body or towards the back. These can also be referred to as ventral and dorsal. Most commonly, though, with our directional terminology, we're talking anterior, posterior. Then we have medial versus lateral. So if we look at, again, at that first figure, we see a line going straight in the middle. That's the midline that divides the body into right and left halves, equal halves. So as we get closer to that midline, say we're starting at the thumbs and we're going in towards the elbows, then our iliac crest, then our vertebrae, we're going medially. If we're starting at our vertebrae and going out towards the ribs and we're going out towards the elbows, then we're going laterally. We're going away from the midline. Next we have cephalic or cephalid. That means superior or towards the head. So if you are looking at an image and someone says, look cephalically, you're going to look up towards the head, whatever direction is closest to the head. Caudal is going to be inferior or closer to the feet. So if I'm looking at the knees and I say, okay, let's go caudal, we're going to then be going down to the tib fibs, ankles, toes. We're going inferiorly. Next we have proximal versus distal. So proximal is going to be closer to the point of attachment. Distal is farther from the point of attachment. What's point of attachment? Think joints, the limbs. So if we say, let's look at the fingers, okay? The fingers are distal to the elbow because they are farther from the point of attachment, being the shoulder. If we look at the elbow is proximal to the wrist because the elbow is going to be closer to the point of attachment. Now, it's really careful about, you need to be very careful about the order of these terminologies. Um, it can be really tricky. So, if we're saying the wrist is proximal to the fingers, that's true. The wrist is closer to the point of attachment. But if we say the fingers are proximal to the wrist, that would be wrong because the fingers are distal to the wrist. I know it's confusing. It takes a little practice. There's some examples in the PowerPoint notes section, and then review that section in the book. It has some pretty good definitions of this terminology. Finally, we have internal and external. Most commonly, this is going to be referring to rotation. And then supine versus prone. These are positioning terms. So if our patient is laying on their stomach, they are prone. If our patient is laying face up, they are supine. Next, we have body planes. These are our sectional images. This is how our pictures are going to be labeled. These are the planes that we're going to be using to visualize anatomy in this class. You will learn to recognize a picture, determine the plane, and then locate that critical anatomy. So we have our mid-sagittal. Sagittal means that we are dividing the body into right and left halves. We have mid-coronal, which means that we are dividing the body into anterior and posterior halves. Then we have our transverse, axial, horizontal. All mean the same thing. We're then dividing the body into superior and inferior halves. Oblique just means that we are adding an angle to any of these planes. Okay, so let's start with axial. So again, axial, transverse, horizontal, it all refers to the same thing. So you're going to see all of these different terms used in your book and on your exams and your quizzes. Know that we're referring to the same plane, the same slice. So this plane divides the body into inferior and superior portions. CT primarily uses this imaging plane. MRI can also use this plane. So can ultrasound. Ultrasound, we can obtain images in the axial plane as well. So if we look at the picture in your upper left corner, that is an axial slice of the abdomen. So we see the big organ to your left, that's going to be the liver. So imagine that we just took our hand and we cut in the middle of our torso, and then we looked down inside that torso. We took the top part off and we're looking down. That's what this slice is going to show. In our middle bottom picture there, we see an ultrasound of a brain. This is most likely a fetal brain. And then if we look in our upper right corner, that's an MRI of the brain. We see the eyeballs looking out on the superior portion of that, which would be the anterior portion because it's closer to the front of the body. But this is an axial slice. We're dividing the body into top and bottom portions, superior and inferior portions. Next up is the coronal plane. So coronal plane is going to divide our body into When you hear the term modalities or imaging modalities, it refers to different branches within radiology. So CT, MRI, ultrasound, X-ray, these are all imaging modalities. Um, there are many different technologies of how to obtain medical images, and each modality, each technology produces very different pictures, which makes sense. If all imaging modalities produce pictures that look the same, we wouldn't have a need for all of them. So CT, MRI, X-ray, ultrasound, all of the pictures produced by these machines are very different. They are all used to diagnose, but they're used to diagnose and view different anatomy, pathologies. Some are better in trauma situations, some are better for children or pregnant patients, some are better for soft tissue, bony structures. So there's a reason behind the use of each imaging modality. The imaging modality assignment will introduce you to a few of these imaging methods. But if you want to learn more about medical imaging as a whole, as a department, as different technologies, I strongly recommend, if you haven't already, to take RTE 101 and or DMS 101. They're both going to help you understand the field a little bit better. When you think of medical images, the word radiation probably pops into your head. Many people think of radiation as harmful to your body. X-rays, avoid it. Ah, scary radiation. The word radiation means the process in which energy is emitted as particles or waves. It is the process in which energy is emitted, transmitted through space or matter, and absorbed by another body. Radio waves, microwaves, visible light, X-rays, gamma rays, these are all forms of radiation. And we use RF, X-rays, gamma rays, all in medical imaging. So any imaging modality that uses these are actually considered to have radiation. So you may have seen this chart before. This is a pretty simple diagram of the electromagnetic spectrum. So these are all forms of radiation. The radiation that we're concerned about in medical imaging is called ionized radiation. Ionized radiation means that the photons have enough energy to knock an electron out of orbit. So let's look at the electromagnetic spectrum. X-rays and gamma rays have high energy. They're located on the far right side of our spectrum. So because they have this high energy, it's enough energy to cause ionization. It's enough energy to knock an electron out of orbit. Radio waves and microwaves on our clear other end of the spectrum have low energy. It's still radiation, but it's non-ionizing. It does not have enough energy to knock an electron out of orbit. So it's this ionization that causes the potential for biological or cellular damage. So think back to your atom structure with your nucleus in the middle and your electrons orbiting around in the orbital shells. So it's those orbiting electrons that are going to be knocked out of orbit with ionizing radiation. So we have this high energy, let's say it's an X-ray photon. We have this high energy X-ray photon coming at this atom. That photon's going to hit that atom and it's going to hit it with enough energy to knock one of these electrons out of orbit. So it's the knocking of that electron out of orbit that's potentially causing damage to whatever organism that atom is a part of. So if it's a part of a cell, it could cause damage to that cell. So X-ray, CT, these are both considered ionized radiation because it uses X-ray photons. It's not a guarantee that biological damage is going to happen. It doesn't mean that patient is going to have cellular damage because they're having an X-ray or CT, but the potential is there. That's why we limit dose in X-ray and CT. We want to limit the patient's exposure to that ionized radiation. Ultrasound and MRI, these are both considered non-ionized radiation. The energy behind the sound waves or the radio frequency waves used in MRI do not have enough energy behind them to cause ionization to occur. So ultrasound uses sound waves to obtain images. Sound waves are transmitted through a probe called a transducer. You might have already learned that in 101. So the transducer emits sound waves into the body. The waves then hit anatomy and bounce back to the probe. It's a technique similar to echolocation, like with bats. So again, these sound waves are such low energy that they don't even count as electromagnetic radiation, but it is still energy that transmits through matter and space. Ultrasound is useful for imaging soft tissue structures. So it's not a great tool for imaging bony anatomy or to evaluate for things like fractures. Because it is non-ionized radiation, there is no potential for biological damage to occur because the ionization isn't occurring. That's why ultrasound is so useful for analyzing fetal development. There's no biological risk to harming that baby. Technology advancements in ultrasound have also allowed for reconstructing algorithms to form 3D images. So with ultrasound, we're getting some cross-sectional slices, but now with technology, we can use the computer to put those slices together and form a 3D image like this baby picking its nose. Computed tomography, or CT, does use ionized radiation because it's using X-rays, and it's using this ionized radiation to obtain cross-sectional images of the body. So yes, CT actually uses an X-ray tube, but the X-ray tube, unlike traditional X-ray, actually rotates around the patient to obtain these sectional pictures. That's why CT looks so similar to an X-ray though, that same grayscale. You're going to see the same structures as black or white. The same structures are going to appear in the same shade of gray as an X-ray and a CT. So example would be bones, right? So bones are going to appear white on both CT and X-ray because they absorb X-ray photons. Air, like in the lungs, will be black on both X-ray and CT because it's not as dense. And because it's not very dense, X-rays can pass right on through it. So most CT images are obtained in the axial plane, but with, again, technology advancements, some CT machines are able to obtain multiple imaging planes like axial, coronal, and CT. I'm sorry, sagittal. All right, so let's look at this axial abdomen CT picture. We can see that the patient is laying on their back. Okay, so they are in a supine position. We're looking kind of from the head down to the feet. So imagine your patient's laying flat on your back and you're starting from the head, moving down to the feet and taking different axial slices of their body, all the way down to the liver and to the stomach. So we see the white bone of the vertebrae. And then if we go closer to the anterior portion of the body, we see the stomach. And that big black bubble there, that's the fundus of the stomach. That's the air bubble in the stomach. So varying densities in the body will appear different shades of gray for CT, X-ray, but also ultrasound and MRI. So all of these pictures are going to be in some form of grayscale. CT is often used for imaging trauma patients because it can get very fast pictures of anatomy and pathology. Sometimes we can use contrast media in CT to better visualize anatomy, like tumors. So contrast can be administered via an IV, through the GI tract, through an enema or oral intake, just depends on what anatomy and pathology we're trying to visualize. CT also has technology now that can render very useful 3D images. So they can take those axial slices obtained by traditional CT, use computer algorithms, and they can render 3D images. MRI, or magnetic resonance imaging, uses radio frequency waves and a strong magnetic field to obtain cross-sectional images. This imaging modality can obtain images in all imaging planes. So your typical MRI scan, we're going to be looking at whatever piece of anatomy with axial, coronal, and sagittal imaging planes. So unlike CT and X-ray, MRI images use a varying grayscale. So remember with CT and X-ray, bone is bone is bone. Bone is always going to be white. Air is air. Air is always going to be black. Soft tissues are always going to have the same grayscale density depending on how dense the anatomy is. But what's different with MRI is that things like fat may appear dark in one picture but white in another. And this depends on the image weighting. So MRI technology does offer various ways to view anatomic structures. So MRI, we get a very clear picture of anatomy. Um, And it's important not to memorize structures in MRI based on their black or white appearance. So you actually need to be able to locate the anatomy. You can't just think, oh, this is the little white structure, so I automatically know it's our spinal cord, because that's going to change with MRI pictures. So again, MRI, we're using non-ionized radiation. It's still radiation because we're using radio frequency waves, but it's not strong enough, it's not powerful enough to cause ionization. So even though it's non-ionizing, there are certainly safety considerations in MRI. Because we're using such a high magnetic field, patients who have metal in their bodies, like an aneurysm clip or a pacemaker, are going to be contraindicated, meaning they probably can't have that MRI. Healthcare workers have to monitor uh, what all goes into that MRI suite, so that includes the patient and any equipment. Anything that is a ferrous metal is going to be attracted to the MRI. So we see this picture on the slide, and someone brought a non-MRI safe patient bed into the room. That magnetic field, that force was so strong that the bed actually went into the scanner. Can you imagine if there was a patient who was lying on that bed when they wheeled it into the MRI suite? And actually, patients have died because of projectile objects um, flying into that scanner while they're in there, or patients going into an MRI with a metal object inside of their body when they shouldn't have been in that room. So MRI safety, that's a very important job of the MRI technologist. So MRI is a very good imaging modality because it provides high resolution images. We can clearly see the anatomic structures on the right image, the definition of the vertebrae, the kidneys, the muscles. However, the trade-off with MRI compared to CT is that MRI takes considerably longer. So trauma situations, we want fast imaging, we're going to go into CT. Once that patient's stabilized and maybe we want a better detailed image, then that patient might be going into an MRI. MRI is also a good imaging modality to visualize soft tissue structures, so some vasculature, muscles, tendons, ligaments, because of that high resolution. And that also makes it very useful for looking at smaller anatomic structures. So MRI has a stronger or higher spatial resolution, which refers to how sharp the image is or how clearly you can distinguish between 2 points. Again, just look at the kidneys in the CT compared to the MRI. Alright, so remember I talked about that grayscale, how CT and X-ray have similar grayscale and MRI can have varying grayscale. You can see the resolution difference again between these two cervical spine CT and MRIs. Do we know what imaging plane this is? We're dividing the body into right and left halves. So this is a sagittal imaging plane. Alright, so sagittal images of the cervical spine for CT and MRI. So we see the the differences in resolution, the sharpness of that picture, and we can also see the varying grayscales between the two. Okay. So we can see bright or white bone. See our cervical vertebrae are white, and then on our MRI, the same cervical vertebrae are dark. And that's just because of the different methods, the different technologies of how each obtain their image. But again, it shows the importance that you can't just memorize whether a structure is white or black. Have to actually know the location. Alright, so these are two pictures, both MRI, both a sagittal lumbar spine. So in MRI, there are various techniques to get different types of images. So the MRI tech changed different parameters while scanning to make these pictures look different. So it's the same patient. It's this, and we can see that through our pathology in lumbar 4-5. So this is the same patient. The technologist just changed different technical factors, different parameters, in order to visualize certain structures. And they're doing that because in MRI we like to change our parameters because sometimes it's helpful to see anatomy, sometimes it's helpful to see pathology, sometimes it's helpful to see fat or fluid. So there's lots of different images we're going to be obtaining with MRI. So common MRI weighted images are T1, T2, and proton density. So you might notice in your book in some of these pictures that it would say something like an T2 MRI. And that's just referring to the image weighting of that picture. Alright, so here's the same picture. What structures look different in these two images? Look at the bony anatomy, the muscles, any potential fluid, the intervertebral disc space. So bone essentially looks the same. They're both darker on these MRI images. But what structure would be just posterior to that vertebrae? Right? So our spinal column with our spinal fluid. So on one picture, our T1 picture, that spinal fluid is appearing dark. On our T2 weighted image, our spinal fluid appears bright. So that's the main difference between T1 and T2 MRIs. Is with a T1 we're going to have dark fluid. With a T2 we're going to have bright fluid. For this class, you don't need to know the difference between various MRI weighted images. However, again, it's important to remember that when you're looking at an MRI picture, it's going to be varying grayscale. So don't just say, oh, on an MRI, cerebral spinal fluid is always going to be white, because it's not. All right, so you survived your first RTE 255 lecture. I know that was a lot of information. There is new information in this compared to the first chapter of your book. I just want you guys to understand a little bit about the different modalities before we really dive into looking at these pictures. Really look at those anatomic directions. Remember anatomic position. It is very important to read these chapters in your book. PowerPoints are just going to be supplemental. So if you haven't read chapter 1, make sure you go back and do that before you take your quiz.